Hello, my name is Mike Sasser. I'm a paramedic with Austin Travis County EMS. I work with our Integrated Services Division, and I oversee all of our substance use programs. I was on the committee planning this one, and I was asked about a lecture that I wanted to see, and this is the lecture I wanted to see, and these are the people I wanted to see give it. I have some canned bios, but I thought it'd be more fun to tell embarrassing stories about each of them before they get started. But I won't do that to them.
Thank you for the suspense.
What I will say is that I've been a paramedic now for 30 years, and Dr. Abraham is hands down one of the coolest medical directors I have ever had in my career, and we are so lucky to have her and to get to work with her. And what Kim and Kenny have done in building our mental health response program has been some of the most impressive things I've ever seen in my entire career. So I will let them tell you a little bit more about themselves.
Okay, I guess I'm first up. Hi there, my name's Kim Griffith. I'm a captain with Austin Travis County EMS. I'm currently the captain over our mental health response program and was one of the founding members for that program along with Kenny. It's been a hell of a ride. It's been a lot of fun, and basically everything we do is fundamentally built in creating another solution for 911 calls for mental health, because I think we can all agree that what we historically have had is pretty limited. And we're going to talk more about that in a bit.
Awesome. Hey, I'm Heidi Abraham. I'm the deep breath, Chief Deputy Medical Director for Austin Travis County EMS. We've got to come up with an easier acronym for that one. So now I'm responsible for much more of the overall system, but up until a couple months ago, I was the medical director specifically for integrated services, which is our whole mental health, substance use kind of group. And it's just been so exciting to work with folks like Mike and Kim and Kenny doing stuff that doesn't get done in most other EMS systems in the country. And the opportunity to take care of these patients and meet them right where they are, under a bridge, on the side of the road, in their home, wherever, and actually be able to bring them help and hope and solutions has been really exciting.
Geez, I can think of some acronyms if you want me to come up with some things for you. They're all very friendly. Yeah. I'm Kenny Pailes. I have been in public safety since 1996. I'm a paramedic that gets the pleasure of working with these wonderful folks too. And don't let Mike fool you. He has been just as innovative and inspirational in his creation of the substance use program that we have here in Austin Travis County. And I think that a lot of the stuff Kim and I have done and our coworkers have done with the mental health crisis response was really just trying to stand on the shoulders of folks like that Mike that had done so much innovation before us. But the real thing, I'm just going to echo what Dr. Abraham said. It's working with especially vulnerable communities that is the most rewarding, and tying meaning to work, as I'm sure all you know, is just so important. So yeah, I guess that's my intro.
Cool. So for the objectives for this training program is going to be, we're going to explain the differences between assessing, treating agitation in a clinical versus a community setting. We want to recognize and define a scale of agitation in a community setting and identify treatments for agitation in presence of substance use disorder. We'll start with the first question is, why EMS? Why are we the ones responding to these calls, and are we really the best resource to respond to these calls?
I think we're acting like we didn't plan that I would start the answer on that. This is not scripted, but we did try to kind of understand who would be best to kind of kick off some conversation. And certainly if there's something that we say that you'd like more clarification on, please, do ask questions, although we'll have some time reserved just for Q&As at the end. And in regards to this question about why EMS, I think you have to take a step back and think about what EMS is. And I know that that's not an easy definition, but throughout the nation it means different things at this current time. But the way we think of it is that we are our community's healthcare providers when a call for help comes through the 911 system. And so a lot of times when we're thinking about agitation, psychosis, if somebody is in the community experiencing agitation, psychosis, the particular scenario that we use when we're training our new mental health paramedics a lot, I don't know why this has become such an anchoring scenario for us, but you can imagine somebody in the community at a bus stop in front of a supermarket next to a busy road with maybe a school across the street. If that person's experiencing agitation or psychosis, They are really going to present to everybody around them as acting outside of the societal norm. That's really what it is. And what do people do when they see somebody outside, acting outside of the societal norm? If there's any perceived threat, and in that kind of scenario we have, you got school across the street, flow of traffic, a business, a bus stop, sometimes people are so uncomfortable that they genuinely perceive that as a threat, they're going to call 911. At that point, how does our 911 system view that? And from our perspective, a core ethos is that mental health care is health care. And going back to what I said before, we are our community's healthcare providers when a call for help comes through 911. And therefore, we want to be the lead on viewing this person not as a threat, but as a patient. That's what we can provide when paramedics are taking lead on agitation psychosis.
I think it's also, in some ways, it's a lot easier to help these folks in the pre-hospital environment or the out-of-hospital environment, rather than bringing them into a sterile emergency department where we're going to take away all of their belongings, disconnect them from a lot of their support networks, stick them in a bare, empty room with nothing else there. Maybe they get a blanket kind of thing, as opposed to meeting them right where they are in their familiar setting to whatever extent, and being able to relate to them a lot more at that level.
One of my favorite ways to talk about this is our historic solution has been one of two things. It's been, all right, you're getting some handcuffs, we're going to jail, and you're going to get all of your rights stripped away, all of your items stripped away. You have no control, no agency, no nothing. And the less bad option is we take patients or people that are just experiencing psychosis or stimulant use or any other millions of causes for these disorders, and we're going to take them and put them in a loud, bright, strange place where people will touch them a lot. And that's usually not a pleasant experience for anybody involved. So there's got to be a better answer. And we think that EMS is going to be the best suited to provide that answer.
What are the biggest logistical issues when addressing agitation in a community setting?
He looked at me like that because I get the elephant in the room. Law enforcement, right? Like, we all know when you call 911, pretty much the stereotype and frequently the only response you're going to get is going to be cops. And the majority of police training and equipment and tools and policies are based about control, right? We need to stop this person from acting like they are. We need to stop them from using. We need to stop them from making other people feel uncomfortable or like a threat. Currently, they have, I guess that was me. Currently, they have next to no tools that actually treat patients like people because they don't really have an ability to do that. They don't carry anything for like medical assessment. They don't really have a strong ability to connect to social services. Am I still working? Okay. The feedback gave me a little bit of a, and what we would like to do is we would like to give another solution here, rather than just focusing on controlling this person from the environment for the comfort and safety of everybody else, right? Because all that does is treat them as a threat and not as somebody that needs help. We are there to provide that help. And in our experience, we've been doing this for 3 years, law enforcement has actually been very thankful that we are there to provide that help. They also recognize that they have limitations here. They do not have solutions that are well suited to this person. So when we show up and we go, hey, we can help this person, we can give them medication, we can give them treatment options, we can do something other than an ER or jail, the majority of the time they are more than happy to step back and go, please take lead on this. Because then they don't have to worry about having to use force. They don't have to worry about following specific laws. More than once, I've had an officer say, hey, I know this person needs something from their home. I worry that there's going to be a substance in there that by policy I'm obligated to make an arrest for. Can you go inside and go get their stuff, right? And they're working with us. It's not always perfect, but it's nowhere near the uphill battle that we anticipated because they also recognize that there is a failure here. There's a systemic failure that we need to do better on.
I think if we talk about the limitations and difficulty of assessing agitation in the field, though, there are probably some things that we encounter that are a lot different than, say, being in a clinical setting and being called to a room or a bed where somebody has already anchored you on what might be happening with somebody, right? So somebody's already said, hey, this person came to our facility with this history of substance use, and right now they are, appearing psychotic or whatever. They might even offer you some more clinical description before you're interacting with them. And a big barrier out in the community, of course, is that we don't get the benefit of somebody else's assessment first, or if we do, it's not a clinician. And so we have to be really careful about anchoring biases. And, like our medical director would be really happy if I use the words premature closure. That way, yeah, thank you. I got a kudos. She wasn't on mic, but I'm going to take it. But there's some other things as well, right?
Yeah, no, absolutely. There are logistics simply, right? Like, is this person able to understand you? Are there loud background noises that are, the more stimuli you have, the more stress anybody involved will be under, including us? Are there a bunch of bystanders around that really want you to take one course of action that may not be the best for that person? There are a million different environmental concerns, and the environment always gets a vote. So part of what we do is make sure that we can, compensate for that environment as best we can to make sure that we are treating that person, that patient, the most effective way possible.
Yeah, those environments can be fairly chaotic, and if you haven't had a chance to go spend some time with, EMS or some of those other folks out there, yes, it's a benefit to be able to meet that person where they are, but boy, there's a few challenges in the middle of that. I think one of the challenges that I think about a lot, especially from the medical perspective, I know this kind of gets us into some of our other questions here, some of the challenges with making sure that we're providing appropriate care for these folks. This was a big thing that I had to get a little bit more comfortable with moving from the emergency department setting out to the pre-hospital side. In the emergency department, when these patients or when these folks come in to see me, I order a whole panel of labs. They get blood counts and electrolytes and check for infection and all the things, right? Out in the pre-hospital environment, we don't have access to that kind of stuff. We don't do blood work, we don't do labs, any of those kinds of things. And one of the trainings that we do very specifically with all of our paramedics in the integrated services program is something called the red flags training. And that's where a lot of times these folks may have some minor complaints. I also have back pain, or I have, whatever, a headache, something like that. Jaw pain that we're used to just chalking up as, oh, you just have a headache. Well, there's some really dangerous life-threatening conditions that can present with those. There's a lot of dangerous life-threatening conditions that can present as substance use or a mental health issue or something like that, right? Low sodium can make you look really confused and agitated and, all that kind of stuff. Sepsis, especially as patients get a little bit older, a urinary tract infection, a head bleed. Like, all of these things can present like what would otherwise get, this is a mental health or a substance use or something like that, right? So being able to train the medics on here's this, like having a broad differential diagnosis, not having that premature closure, thinking outside the box, like being aware of all the other medical diagnoses that can present like this, and then being able to do a good assessment still, and sometimes be able to step in and say, hey, I know you guys aren't thinking about these things because you don't have the training or the background or the experience in it. I'm telling you as a medical provider, I'm worried that this person has something else going on that we need to go and get checked out and get treated. So being able to be an advocate for the person in that sense and say, I'm looking at the holistic picture and concerned about the rest of your health as well as whatever is going on right now. Yeah.
So what are some of the biggest potential risks in addressing agitation in a community setting?
Yeah, so that. So I mean, that's a big one, is the potential that we're missing something. Now, I will say we have gotten a lot better. There's, so I'm going to use some EMS terminology here, and I'll try and define everything as we go. So Texas is divided into RACs, Regional Advisory Councils. Here in Central Texas, we have the CATRAC. I see a lot of people nodding their heads. San Antonio has STRAC, South Texas Regional Advisory Council, and these regions are able to kind of get together and collaborate on some of these bigger projects. One of the really exciting things, and STRAC kind of started for us down in San Antonio several years ago, and we've been able to piggyback off of them here in Austin. They created a protocol where folks who needed to be admitted to a mental health facility of whatever sort could go straight there without having to go through the emergency department. So people who met certain criteria, and it was a lot of kind of obvious stuff, right? Like they haven't intentionally tried to hurt themselves, they haven't been cutting, they haven't caused some kind of physical trauma to themselves, they haven't overdosed on a substance, and they have fairly stable vital signs. Those folks can go straight to whatever appropriate mental health facility rather than having to go to the emergency department. And the exciting numbers that San Antonio and STRAC have seen, there have been no negative outcomes from that. They have had no patients that we've taken to those facilities who ended up decompensating, getting worse, having something that we missed. So it's really exciting. I mean, they have numbers in the thousands at this point to be able to say, hey, it's safe. Like, not everybody needs that full medical assessment in that sense. if they have this kind of assessment and they meet certain criteria and everything looks good in the pre-hospital environment. So that's been really exciting to be able to do that. But that's one of the things that's always at the front of our mind is, are we under triaging these folks? Are we missing a big medical, some other diagnosis here? One of the things that I worry about a lot is provider safety. EMS is already a fairly unstable environment. I think back to a call that I was on just yesterday. It was a guy it was a super minor motor vehicle crash, but the guy was having some neck and back pain and called us out to assess him. Lives out of his car, had his 2 dogs with him in the car. Probably both very nice dogs, but they're both like giant German Shepherds, right? And I spent the entire scene throwing a stick back and forth for the big dog that jumped out of the car to keep the dog distracted and let my paramedics focus on fully assessing the gentleman and making sure that he was taken care of. I don't have to deal with that when I'm working an ER shift. Dogs are not allowed in my ER. So just provider safety in general, right? Everything from the pets to the potential for escalating agitation, causing harm, that kind of stuff. And I know if one of y'all wants to speak to that, because we do a lot of...
Actually, so provider safety is usually one of the number one questions we get when we're like, well, when we say we don't need law enforcement on every scene, right? Well, how do you handle the safety issue? What I have for that is numbers, and that is after 3 years and several thousand contacts, I think we've had emergency, like, hey, I need help, 4 times. And of those 4 times, I think only 2 resulted in minor injury and none with major injury, and all of them were patients where an ambulance was already on scene, and this patient had something medically going on that was causing them to be extremely combative. The number one defense against patient escalation is not control, it's rapport. And one of the ways that we accomplish that is we minimize the number of stimuli on scene, we minimize the number of providers on scene, and we train our paramedics very well in de-escalation and in creating that rapport with their patients. And that way the person does not feel like they are being confronted with a threat when they're already undergoing a crisis.
Well, and that's big, and I don't know if we're going to talk about this somewhere else, but what do you want to talk about, like the training that would go through to kind of, and I forget if that's somewhere else or if this would be a good spot for it. There's a tremendous amount of training to help minimize the risk for that.
You're the medical director. We'll talk about it whenever you want to talk about it. In addition to the training, I think a thing that we can come back to that isn't here is kind of our own retroactive statistical analysis of how frequently we do use law enforcement. And so we haven't really talked about our deployment model, but I can sum it up real quickly, which is just what we're talking about with our folks is a co-response model, ideally, where we have one of our specially trained, what we call mental health paramedics, in an SUV with a qualified mental health professional from our local mental health authority. But one of the challenges is that we're staffed 24 hours a day, and the local mental health authority really doesn't staff 24 hours a day as well, or as easily, I should say. Not a judgment call, just logistical reality. So often it's just our mental health paramedic going. And I would say mental health paramedic, these are all folks that have applied, gone through a competitive process to be on our team. I think we have a mean experience of about 12 to 15 years as field paramedics, and then we put them through an additional 3 months sort of custom created curriculum that we've done. And that's that training, that 3 months of training. We do involve the local mental health authority in that. So they take a deeper dive into differentiating mental health disorders. We also work with the other functions like the substance use program. We shadow our local mental health authority, and then we have a lot of extra material that we've built just from doing the work, like agitation assessment, which we try to do in a clinical way. I don't think we've necessarily said this yet either, but a thing that we noticed is I want to be careful about how I say that. Okay, yeah, I'll not say that one. But I did, on the retrospective view, so I don't forget about that, we found that when our model, when our mental health paramedics make the scene of a call that is call typed as a psych call, 88% of the time, the disposition does not involve an ambulance. So 88% of the time, they're not going to the ER in an ambulance, which is usually what people, going back to the first talk, when people think of EMS, they just think of ambulances, and ambulances that go to ERs. And we're trying to shift that to being a model that's focused on paramedics, and not necessarily ERs, but a whole lot of other options we'll talk about. in addition to the 88% of the time we don't use an ambulance, 94% of the time we don't use law enforcement. So that is like documented statistical demonstration of how effective this can be when it's a kind of patient-centered model. You want to chat about that?
I guess to add to that, I believe one of the reasons that our training is as effective as it is and we're getting the outcomes we are is because when we approach agitation, we're considering two things. We're considering the patient as a person, right? And we use a trauma-informed approach, understanding that if they are experiencing this once, this might have happened in the past and they might have been placed under an emergency hold, had all their rights stripped away, had a bunch of people pin them down, involuntary sedation. Like that is a deeply traumatic experience for anybody. And we pair that with a clinical approach, because we understand that in order to be able to treat a patient and a person, we have to understand that mental health care, substance use are all health care, and we have to treat them as such, while also still maintaining the knowledge and continuous approach that you are a person that is undergoing a traumatic event. And that is what keeps us safe, that is what keeps them safe, that is what makes us have better outcomes.
Kim, do you?
I got another question that's not on our list. How many unique dispositions have you come up with for mental health calls that don't involve law enforcement or hospitals?
Over 42.
Over 42, and it's always
so
going to stay over 42 because we're Hitchhiker's Guide to the Galaxy fans. So 42 is always the answer one way or another.
It's kind of become a game in our system where we're like, we take some challenging situation that nobody's been able to come up with a solution for, and we throw it to the integrated services medics, and we time them to see how long it takes them to come up with a solution.
For stimulant
5 minutes.
use and psychosis specifically, will range from like, cool, we're going directly to inpatient detox, or we're going to a sobering center, or we're going to treat in place with a couple different medication options and refer you back to your current care team. Like, it'll drastically vary based on the patient's like prior needs, prior care team that's set up, prior care, what their history is, all of that. So there's not really a great clear answer for any one situation because everybody's needs vary so much.
Kim, you were talking about challenges in assessing agitation in the community, and I think a point that I want to see if you agree with this, but a point that we've noticed is sometimes our law enforcement partners might use a word that they've heard us say, like, oh, this person is agitated, and therefore you should do this or do that. And there are a couple of things that we've learned. One is we never take medical direction from law enforcement. Like, that is just not a thing that paramedics do. But two, the real challenge for us was for our people, we're very, 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 very specific about this. They must be able to clinically describe the state of agitation. And that's not a challenge that's given to anybody else on that scene. So that's maybe where you want to talk about that.
The big thing there for agitation is understanding when you use the word agitated, that means different things to different people, right? Like every person in this room will have a different view of what agitated means and have a picture of a different person in their brain, regardless of the cause, whether it be stimulant use, psychosis, underlying medical concern, like anything. So one of the issues that we had is we had to make sure that we were objectively clinically scaling agitation the same way with all of our providers on every patient every time. That way we are not allowing unintentional and unconscious bias to inform what we are choosing to do for treatments for this patient. We do it in EMS already all the time. In the medical world, scaling is like ubiquitous. We use it for strokes, we use it for trauma, we use it for level of consciousness. Like it's something that is used every single day by every single medical provider, probably at least around the nation and probably around the world. And we were not doing it for agitation. So we started. And that is one of the reasons that we have been so successful in de-escalation is because we were able to recognize this person is not the true level of agitation where you're like, oh, we should sedate this person immediately. You're upset and you're yelling because you're upset, and if I were upset, I'd be yelling too. So we're gonna give you the space to yell a little bit, and if we start getting physically aggressive, then we might have a conversation and reassess this. But until that point in time, you're still just a person who's yelling, and that's okay.
In our, really not sure if this is working half the time, but in our training, we call it a RAS from the door. So do you want to talk about RAS? But basically, the core of that is just, I know that they're based on the professions that are represented here. You're familiar with CWA scores and COWS scores. In the hospital setting, the RAS score is this Richmond Agitation Sedation Score, RASS. I always, in my head, it's RAAS, and I don't know why. But the RAS
the
score,
kidneys.
that's right, that's a whole other medical thing. Okay, let's just pretend you didn't hear that, Heidi. So we decredentialed, she just wrote on that paper. The agitation scoring or scaling that was used basically like in an ICU setting, where you might have somebody who can't verbally talk to you about what they're experiencing, but you're going to use observations to determine whether or not you need to dial back or dial up their sedation, for instance, or if you've over-sedated them. So it's a negative score and positive score. We modified that for our application, and so in our training, our new folks learn very quickly. What we expect them to be able to do is, without looking at a reference, although we're not against looking at references in other settings, but for this case, you should be able to observe somebody and scale their agitation. So tell us a RAS score from the door. Oh, I'm seeing +2. I'm seeing +1. I'm seeing +4. You know, that then helps direct where we're going to go for the rest of the scene. But we also understand it's a dynamic score, and I know you know that too. Otherwise, de-escalation wouldn't exist as a concept.
And we score it again after every intervention, whether it be verbal de-escalation, administration of sedation, you know, like we do a score, and then we do an intervention, and then we score again. Was that intervention effective, yes or no? And we do view de-escalating somebody as an intervention, because what we were trying to do is we were trying to treat their agitation, whether it be via medication administration or even just talking to them. That's an intervention too. But I wanted to say my favorite thing about that is it's created a little bit of a culture in our team where if somebody gets mad about something, everybody else will go, +1! And all just like rile each other up, and it's deeply entertaining.
I draw the analogy to, it's the same as assessing a patient with shortness of breath. I actually just finished doing a lecture this morning for another set of my medics about assessing and treating somebody with shortness of breath. And we spent 30 minutes just going through what are all the signs and symptoms that you might see of somebody who is in respiratory distress. What are all the signs and symptoms that you might see of somebody who's in respiratory failure? What are all the things that you can do for somebody in respiratory distress? What are all the things that you can do for somebody in respiratory failure? And helping them verbalize like, oh, I can look at somebody and say, you're agitated or you're short of breath. But being able to actually like put words to what is it that I'm seeing helps me recognize, oh, for that, I have all these other interventions that I can do, right? For somebody who is having shortness of breath because of their asthma exacerbation, there's a whole bunch of other medications that I can try first, depending on what symptoms I'm seeing. But if I see certain symptoms, I got to intubate that patient pretty quickly, right? It's the same thing when I'm managing somebody with agitation, being able to verbalize like the things that I'm seeing in terms of whatever assessment to say where they are on that agitation score. Helps me identify, oh, when I'm at this level, here's all the different tools that I have to work with that. When they're at this level, things are getting a little more concerning for them. For their own safety, I may need to do something else quickly, right? And being able to have, like you said, that standard objective score that everybody's using exactly the same with guidance and kind of established standards for when you see this, this is, you know, the things that you can consider when you see this, these are the things you consider, I think helps a lot with safety for both the crews and the patients.
Cool, thank you. I talk all day, every day, so I'm totally fine sitting back seat on this one. What are some common confounding factors or mimickers that you need to assess for, and how we do it? I think we already kind of addressed that one with.
So we kind of talked about that some, just in terms of all the other, you know, infections, electrolytes, head bleeds, all that kind of stuff. One of the things, I know we've been talking a lot more about mental health type stuff, but I want to hit a little bit on substance use as well. Substance use disorders. So Mike obviously started the buprenorphine bridge program here at Austin EMS. Probably one of the most exciting things I've ever gotten to be involved with in all of my medical career, right? But that's one of our big challenges also, is figuring out how much of this can we treat in the field, how much of this is, hey, your symptoms are severe enough that we need to actually take you into the hospital to better manage those symptoms. And just doing a lot of education on, you know, what our options are out in the field. We are fortunate enough that we have both physicians like myself and physician assistants out in the field on a regular basis who can run over and meet up with the crew, you know, wherever, and assess that patient and figure out, hey, I can prescribe you more medications, we can safely manage this here, or your symptoms have gotten bad enough, I'm worried about maybe some other additional stuff that we need to take you into the hospital and get you assessed for. So bringing in the, you know, medication side of things.
I guess one thing I do want to specifically mention, like, especially for psychosis, right? Like stimulant use versus organic psychosis, and they frequently run together. It can be very difficult to differentiate between the two. The nice part is that, like, we have some treatments that work well for both. So it works either way. But the other thing that we're also very cautious with is when somebody is self-medicating with substances due to organic psychosis, they're not necessarily self-medicating with a single substance. And one big red flag that we go over a lot is alcohol withdrawal, because it can be conflated so easily with psychosis, right? Like hallucinations, delirium, tactile hallucinations, agitation, all present very similarly to stimulant use. So it's like we have a lot of literature and training on, hey, these are the things you have to rule out, because alcohol withdrawal can kill you if it's not treated.
Yeah, and obviously it's important to mention, even if folks think that they are self-medicating with one substance, depending on where they got that substance from, who knows what else they may be getting at that point. So being able to kind of recognize some other stuff that may be in there and take care of that appropriately.
I'm going to add one little bit to it, which is just that, and I think there's a lot of what we're saying you already know. I've kind of had a chance to see who's in the audience and meet some of the people here, and I'm like so impressed by the expertise and experience that you have dealing with people who are suffering from either not having unmet mental health needs or substance use issues. So I think that one thing when we talk about this is when you have a bit more experience, there is some pattern recognition. Think about the times where you've seen somebody and thought like, that's mania, that's earmuffs. It's sort of leaning towards premature closure, but we certainly train our people to trust intuition. Intuition is an important part of mastering any skill, including clinical practice, but not only focus on that intuition. So still keep this clinical curiosity and it looks like mania, but maybe this is the one that looks like mania, but is actually something else. And to Kim's point, sometimes it doesn't really matter. We're going to treat agitation when we have clinically objectively scaled it very similarly, somewhat regardless.
Just to underscore that, intuition is wonderful. We are always backing it up with objective clinical assessment. That is the absolute expectation for every member of our team. Your intuition's great, but it has to be backed up with objective findings that you can document and say, cool, I know what this is, because intuition is very vulnerable to bias.
What are some treatment options for patients experiencing agitation in a community setting?
Oh, yeah. Okay, so I'm going to start off actually by talking about, I think, what we've already sort of mentioned, but I want to be really specific about it. A lot of communities are doing what we're doing, where there are co-response models and attempts to push more mental health expertise into the 911 system. So I want to make sure we're not presenting ourselves as the only ones or first ones doing that. But we're about to get into some stuff, I think, that is very unique, and from what we've been able to tell, maybe we're the only EMS system in the country doing it the way we're doing it now, and maybe even the only EMS system in the world doing it right now, and as not to pound our chest and say that's the way we want it to be, because it's opposite. We're actually here talking about it and in other places talking about it because we want this to be more common, including in your communities. So the keywords, diversion, and I will warn you that in working in your communities, when you use the word diversion, we learned this the hard way through one of our major funders. We were talking to our partners, one of our publicly funded entities, and we were talking about diversion, they were talking about diversion, we're talking about our numbers, they're talking about their numbers, and none of them matched up. And we realized there's an entire body of research that uses diversion only to mean diversion from the justice system, criminal justice system. And everybody's nodding because they're like, yeah, why else would you use it? And we're like, oh, our entire career, diversion is from the hospital. And actually isn't even that common. It's a relatively new idea that we would divert from a hospital to somewhere else, or that we would divert ambulances away from the scene. But that's I also want to say that we don't anchor on only trying to divert people from the hospital. Our real core mantra is that we try to find the right resource for the right person at the right time, hopefully the first time. That's a little subtext, but that's where the 42 things come in. It's like it isn't that we want to keep them out of the ER. We actually want to be able to recognize when they should be in the ER, and that is so, so, so important, and our medical directors keep us so focused on that. And we haven't had an adverse event in 3+ years that we've been doing this. But yeah, so what other things are there other than the ER? Well, one thing that when we spoke at a conference of national EMS physicians surprised some people We've had a lot of success building relationships with inpatient facilities and doing direct admits. We had to learn how to navigate funding. That was a big thing for us. But we also had to learn how to talk the talk. Some of you might even be in roles where you would be the person I'm talking to, and imagine yourself, you're the person taking phone calls for admissions into a facility, and you get, hey, this is Kenny, I'm a paramedic with the city, and I got somebody I think would be great for a bed. That's maybe not a call you're used to getting, and you might even be thinking like, why is this little paramedic calling me right now and trying to get somebody here? Take them where? Take them to the ER. I get my referrals from the ER. And so we really had to kind of work to help people understand that there's safety in our assessment, both for the patient and for the receiving facility. We had to work to understand ourselves because if you're familiar with a federal law called EMTALA, it obligates the ERs that we transport our patients in ambulances to. They're obligated to accept that patient under almost every condition, and that does not apply to a lot of inpatient facilities. So that required identifying those facilities. It required some hard-learned experience, knowing that those barriers existed, and in overcoming them was a lot had to do with, we're not done with it, but building relationships, which we still endeavor to do today, and also learning the language, because I think anybody will be more comfortable if I can call you as an admissions nurse or any other person in a facility, and most paramedics in the US would never use the phrase AVH, or they would never use that initialism. But just those little tiny bits of jargon that we're not using just to use as jargon, we're using them because we have also incorporated them into our assessment. But they went a long way towards helping us open up other doors.
And this is in recognition to the fact that currently, if you are a patient that we encounter in this arena, like we have psychosis, either secondary to stimulant use or organic psychosis, your options are limited when somebody calls 911, and every link in the chain that we add, every person, every facility we go from like ambulance to ER to facility, like that's the best case scenario. Those are 3 links in the chain that can break, and you can just be lost to the system, and you get discharged, and you have nothing that actually resolves your problem. We're gonna be right back here in 6 hours, right? And that is deeply traumatic and disheartening to see and to experience over and over and over again. So one of the big pushes that we have for this for alternative disposition is so we can remove those links in the chain and make sure that people actually get to the help they need when they need it.
I'm going to jump ahead just a little bit here. We're going to talk in a little bit about how do you do this at your own institution. And it's important to have champions both at the paramedic level, and you have to have your medical director on board too. I saw a couple EMS agencies in here. Not to toot my own horn, but I can speak at a different level to some folks at those organizations that, right, Kenny's like little old paramedic walking up saying, I need you to take this patient. I can pick up the phone and call their medical director and say, hey, I've assessed this patient, here's what I found. I can speak that physician's lingo and get a lot more buy-in at that level also. So being able to have just partnership at multiple different levels, involvement in champions at multiple different levels within your organization so that, yeah, like they do a fantastic job of marching. I mean, Mike will tell you, you show up in a uniform somewhere and you can get all kinds of stuff done, right? But just having people at all the different levels who can, speak peer-to-peer and kind of push some of those conversations.
I don't think we've said very many specific alternatives, though. Do you want to start? Yeah.
Skip question 8 and just send you to Zyprexa.
Yeah, we think, you're doing great.
You want to repeat? Repeat what you said?
Cinco.
Tell me about Zyprexa.
Okay, I can do that. Yeah, so this is something, it's a program that we've been working quite a bit with Round Rock Fire to implement with them as well. He's like, yeah. So what we started doing about a year and a half ago, a little less than a year and a half ago, was we started carrying Zyprexa as an alternative to, as an adjunct for alternative disposition for patients with low acuity psychosis, including patients with stimulant use, as long as their vital signs are within stable parameters, so that we can relieve AVH, delusions, other symptoms in place, and then connect them to appropriate care. The idea was initially born after realizing from doing this for 24 hours that after about 5 p.m. to 8 p.m., your options go to 0. You go to an ER or you get no help at all, right? Or we get medical direction to agree to Haldol or Droperidol and hope that you have somewhere safe to sleep it off, which is not always great for patients. So instead what we do is we carry Zyprexa, we work with patients, we have a procedure that we created and qualifying parameters that they need to meet that was created both via us and our local mental health authority to make sure that these patients were safe to leave in place both from a medical and mental health standpoint. So like they have insight into their delusions, they're grounded in reality, they're willing to participate and collaborate in reaching resources, and they have to be connected to resources within 24 hours. One of the other reasons that we use Zyprexa specifically is because all of our local like detox facilities, mental health facilities use it as their rescue medication. So we can call them and say, hey, we gave this patient Zyprexa, and their response is, cool, we know that med, we're comfortable with that med, that does not bother us. Versus if we say, hey, we sedated them with Versed or like even more ketamine, and we get the, whoa, we don't know what to do with this. How do we monitor them? What are the effects? What's going on, right? So it works a lot more fluidly with the system that's already in place, and it gives patients options other than, hey, nothing's open, either go to the ER or we'll see you in 12 hours, sorry. And the numbers that we have been good. The last data poll I had, I think we have about 115, 120 patients enrolled. 87% of them were not transported to an ER. I'm actually very glad that number is not 100% because it means we're not missing major medical issues. And I want to say only 8 of them had a follow-up transport within 24 hours, and none of them were emergent. So it has been effective and safe for our patients. We have yet to have an adverse outcome, and we have been able to connect them to all kinds of resources, whether it be, hey, I have an appointment tomorrow, I just need to be able to make it until my appointment, or, hey, we're going to connect you to your prescriber or a different prescriber. We're going to get you to PES for their walk-in clinic. We're going to reconnect you to an established care team. It varies drastically. It just gives us another tool so that we are no longer beholden to the 9 to 5.
Kim, we only have 2 minutes, but this Zyprexa thing has been amazing and opened up doors. The bit about it that's unique, if you're wondering, in EMS, there are other EMS systems that carry Zyprexa, but the way that we're using it that's unique is not to facilitate transport, but to facilitate the least restrictive environment, you know, to leave people in their community if at all possible. And so just kind of like taking that RAS 1-2 down to a place where they're not experiencing the hallucinations and the agitation, and that's really kind of the meat of the talk. But I think one of the most amazing stats, Kim, as a person that pulled the stats, how many of those people, it was a participatory sedation. So how many people?
Oh, 100%. It's voluntary only. It's PO. So patients choose to engage, and they have the ability to say no if they don't want to. It is fully patient controlled. They maintain their agency and ability to decide and participate in their course of care. Because if the patient lacks present mental capacity, they are not eligible for the program. So the patient has to be willing to engage in it and has to want to engage in it for us to be willing to use it.
And it's one of our core principles, trauma-informed care, right? That's that collaborative choice and that empowerment that you're offering to somebody. And this is one of the tools that we can use that actually reinforces that. It doesn't just like, it's not just words, but actually action towards having a trauma-informed approach to somebody who's experiencing, you know, what it must be very terrifying. So, you know, offering them the chance to decrease that terror and not be then also obligated to be in an ambulance, an ER, or jail, or something like that. It's just been amazing.
We're going to go to Q&A. Do you want me to go ahead? I'll go ahead and read one of the questions from online. This is from Maria Perez. It says, if the individual has several co-occurring disorders, is it best to leave them immediately, to have them immediately put on a hold to regulate themselves before assisting with anything else? As of now, if staff referral for someone at the hospital, we will go and do a complete assessment for RSS, but a lot of time once they have been out of there and live in inpatient sober living use, what is a good approach for this?
So, oh, that was loud, I'm sorry. Like everything, it depends, right? But I can tell you that basically what we follow is we treat the most emergent condition first. So if we're experiencing alcohol withdrawal, you're getting treated for alcohol withdrawal. If you have an underlying medical condition that is emergent, we're going to the ER because we have to be stabilized, because at the end of the day, we don't want people to die. Right? We're here to keep people alive, keep them safe and healthy as much as possible. We will frequently have patients with co-occurring substance use and mental health disorders, and it all varies by acuity, right? Like sometimes they are self-medicating with substance use. Meth in particular can cause quite a bit of psychosis and enhanced psychosis, especially when they're coming down from the meth use. And at that point, it really turns into symptom management and saying, are we grounded in reality? What are our safest, least restrictive options available? We always try to tend towards the least restrictive option, and we will address whatever condition allows us to hit that least restrictive option while still considering patient safety. And that's kind of the core of it. I know that's not a great black and white answer, but
No, that's a great answer. I think another part of it is that we have established a stepwise assessment for our mental health paramedics so that we're not missing things. And I think the core of the question was like, what do you do first? And so we have an organized system such that we are always looking first at, of course, safety, that RAS from the score. We do a medical assessment first. We're always paramedics. We do suicide safety screening for everybody, and we have some enhanced training in that as well, including potentially safety planning. We assess people for psychosis, for substance use, either withdrawal or intoxication. And last but certainly not least, in terms of all sorts of confounding presentations and barriers to care, we do our best to assess for IDD. And then after that, of course, we'll dig into like history, meds, that sort of stuff. But we have a stepwise assessment in that way if that helps that person's question. Yeah. I don't know that they're able to respond.
The very next one sounds actually pretty similar. It says, which one do you address first? And I think we already kind of addressed that one. Do we have questions from people that are here present?
Yeah, I was wondering, when you give people the Zyprexa, do you typically do you stay with them for a certain period of time? I'm assuming it doesn't take effect immediately. How does that, what happens afterwards, basically?
So Zyprexa has generally time to effect by literature is an hour, peak effect 6 hours, and then duration's 1.5 to 2 days. We found that after about 20 minutes of monitoring, we're able to note cool, is this going to be effective for the patient or not? So every patient gets at minimum 20 minutes of monitoring. Usually ends up being longer than that because we're still working on, hey, we're connecting you to resources, et cetera. But in our experience, 20 minutes monitoring will tell us, is this relieving your symptoms or not? Or are we calling medical control to say, hey, we need another dose, or we need to consider another avenue?
You want to talk about the dose and route?
Yes. So we carry 5 milligram doses primarily because those are very low acuity. 5 milligrams is used off-label for breakthrough aggression for children on a regular basis for kids with IDD. And it's also much less sedating. It's much more comfortable for patients, and we have the ability to call to go up to 10 milligrams if needed. We also have some patients that have extremely high prescribed dosages that we've called medical control for. We had one that was on a 65 milligram a day prescribed dose. That then ran out of her meds, and you can anticipate what the outcome of running out of her medication was. So we were able to match what the patient's dosages are as long as we reach out to our medical direction.
And that's ODT that we're using, ODT. So we're not having to establish line, push IV or anything like that.
A lot of our patients have trauma with needles.
Yeah, I was going to say that was a very intentional decision to use ODT and not one of the other routes. Oral dissolving tablet. So like Zofran kind of thing, if you stick it under your tongue and just let it dissolve rather than having to chew it or swallow it or anything like that.
Apparently it doesn't taste good, which is not great. But people don't have to swallow a giant pill, which is also helpful.
Thank you, guys. My question is, you mentioned in the model moving from this EMS to ambulance to ER to a paramedic connecting people to a whole host of resources and not the hospital. And I was just curious, this is something that Sam and I talk about a lot, and we're from Ohio, so it's a different landscape of resources, but we have a pretty extensive resources for people struggling with substance use. And if it's co-occurring mental health, you can kind of get in through the substance use door. But if the issue is primarily mental health, what resources or what partnerships with community resources have been the most helpful to you? Because I think sometimes we have the willingness within community paramedicine or our different response teams to do this kind of work, but then they say with mental health, where do we, what do we connect people to? Where do we bring them if not? They don't want to bring them to the ED, but.
Yeah, what a fantastic question. When we presented this to the National Association of EMS Physicians, one of the things we presented was the idea of what I call a mental health audit, which is trying to take a census of your community's resources. So identify your inpatient facilities, for instance, identify your funding sources if you have local public funding. And we can speak to what we have here, but what's more important is trying to be proactive in identifying those things, try to identify their capabilities, try to identify their limitations. Is Ripple Ranch still here? Yeah, I mean, these poor folks at Ripple Ranch had the full-on assault from Kim and I earlier. We came to their booth and just started hey, okay, but do you take this person? What about this one? What about that one? That's what I would do if I were in your position is is try to interrogate a little bit, but also then use those points of context to build those relationships where there are barriers to see if you can overcome them. One of the points of that audit is also that you're going to identify lacks or unmet needs. You're going to find maybe you don't have a place to put somebody who's experiencing, or somebody who is known to have IDD. Or maybe you don't have a place for geriatric classified patients, or somebody who's mobility impaired. So I think there's a lot of value in asking that question about your own community and then trying to problem solve from there. We did, and I mean, but we did it. I wish I could pretend that we did it so intentionally. You know, we didn't. We did it through experience, and in trying to make a model that's repeatable is when we recognize that this is a way that we would have done it if we had to do it all over again.
We basically went from a bunch of paramedics calling facilities going, hey, would you take this? Oh, this is who I am. Let's talk about that, to, okay, we should get a consistent idea of what facilities can do before we start calling 5 at a time.
Template. Yeah.
We have 2. We have a facility capabilities transport grid that like says, hey, can they do detox? Can they take pediatric, adolescent patients? Do they take patients with IDD? Like all of those things, any kind of specialty programs. Then we also have, via our other integrated services partner, C4, they have a OneNote that they regularly update as they find new resources or have resources that are no longer around.
And the question for the people online, if they couldn't hear, the question was, you know, do you have like a Google Doc or some other, you know, resource? And I don't know if the intent was if there's something that you could also use without having to recreate the wheel in your, yeah, we started that. We started to create that mental health audit template. I haven't completed it, but I'm happy to get in touch with anybody. We are all available because we do want to see this repeated, and I think it's a work in progress, you know.
Hi, so I work at Dell Children's, and so I was wondering if y'all could speak more about treating pediatric patients and the challenges connecting them to community resources, please.
Yep, that is deeply challenging, not least because children can't make decisions for themselves. A lot of what we do is we serve as an advocate, sometimes from the child to their parents, and try to make arguments one way or another. We do not have a fantastic solution for especially younger children. Now, I don't believe any of our facilities take below age 11 or so, so unfortunately we're still limited to an ER currently, which is usually you guys, so thank you for that. But we also are a little bit more cautious with the treat and place with children, specifically because they are unable to advocate for themselves. And if there's something we're missing about the situation, like any kind of abuse or lack of resources or access that the parents may not be fully connecting with, we never want to leave a child in a vulnerable position.
Do we have another question in the audience?
Not that guy.
All right, this actually has nothing to, well, actually a little bit. So I'm curious about how y'all are navigating CIT and notices of emergency detention in your county, because that is a challenge that we regularly run up against.
So we have kind of a twofold answer to that. I'll talk about the 911 one if you want to talk about the response one. So on scene, when there's an MHO on scene that we're available, we've gotten to the point where we have a relationship, just, you know, boots on the ground, peer-to-peer of, hey, this is what I think we need. And generally, we've reached a point where the MHO will agree with us. It helps that the law allows them to do an emergency detention based on reporting from a reliable third party. So we have been trained in how to give them that reliable information when we believe a POED is necessary. And specifically deterioration is the one that we end up having to advocate for the most because it's the most difficult to articulate, especially for somebody that has no medical or mental health background. And then for the other, what?
I may not be picking up what you're putting down for me there. I don't want to.
Well, I was going to say the other is if we don't have an MHO on scene physically with us for follow-up, yeah.
Yeah, that's a big challenge. And Cody, I'm not sure which challenges you were talking about with the POED, but one thing that we learned when we started this program from our clinician partners with the local mental health authority is they were often challenged to obtain a POED when they did want one, that they found their law enforcement partners were not really agreeing that this was somebody that needed a POED. And I personally always sort of felt the challenge would be the other way. We've learned a lot from other models in the nation. One is Cahoots out on the West Coast in the Portland area, if you're familiar with them. They actually came and did a ride with us and gave us some feedback. And one of the things they said was like, man, y'all just like take everybody away, huh? When they're feeling like suicidal. And specifically, they were talking about suicidality. And they really sort of opened my eyes, because if you're in Texas, you just think, I think there's like a heavy bias towards taking somebody's autonomy away if they express suicidality. And in other areas, and as a lot of you probably know, there's been a big shift towards trying to really prove that it's safe to do otherwise. And so that, we're challenged in both ways. When it's deterioration, it's like clinical deterioration, often because only law enforcement is empowered to put in place a POED, they're obviously, it's not, they express, I've had them express to me like it's not fair. Like, you get all this training. You know, a doctor gets a doctor in school, and I'm a police officer, and but it's my name on that piece of paper.
We agree it's not fair.
And yes, and that's what we tell them, and we find that we express that, like we build a rapport, we make that connection, and then we kind of really try to express why we really do think this is the right thing, and that's how we try to talk them into that. But the other way is very challenging, which is like, if somebody is on scene and feels they're obligated to take somebody's autonomy away because suicide was mentioned, it can be really, really tough to navigate. And I think the first step to that is just limiting the presence of people who won't have that discretion.
And to add to, when we have like patients that we're seeing regularly, where we're like, we really need a POED on this patient, and like the MHO that is on scene is disagreeing, or if we can even get one on scene, because they are also fairly overloaded for call volume, we do have a different team called CARES, which does follow-ups, and that is a co-staff team with law enforcement, us, and our local mental health authority, and they have built relationships between them to the degree that generally they will have a consensus on whether a POED is needed. So we're able to do a referral to them for probably officers that have a little bit more experience in training, and also have that rapport built with not just us, but with the social worker or clinician that's on that team. And that way they're all able to come together, come to a consensus, and do a follow-up POED.
Trying to break cycles. That it's like postvention, prevention. We actually had like a whole debate yesterday over whether we should call it 911 prevention, because it only comes after the 911 call, but you know, whatever. We're dorks that way. All right, I think we're done with questions. But we have something else.
So thank you all for coming. Thank you for all enjoying it. This is an imperfect call that we have to, a situation that we have to deal with, because somebody's got to deal with it. And I think this approach that we've taken in doing it is one of the best that I've seen in my career, and it seems to be working a lot better than some of the alternatives. Anything that doesn't involve hospitals and handcuffs is a good thing for us, is how I look at it. So we're all for it. But thank you all for coming, and thank you guys for all participating.
Let it go. What you said? She said, let it go. But we do just a quick call to action, and that is, if some of the questions were clearly focused on how can we replicate this. So please come get our contact info, and we will help you all that we can. Thank you.
Yeah. Thank y'all for coming.